I love medical history, and this is easily one of my favourite TV shows. The Knick is set in the hospital the Knickerbocker in 1900s New York. The series features many of the developments in modern medicine and surgery and follows the doctors and nurses who work at this hospital. The time period in which this show was set was a very exciting time in the history of medicine because this was around the time anaesthesia and antiseptic techniques were discovered, so surgeons at the Knick could experiment with new methods and implement life-saving operations with less pain and less risk to the patient. But with all the excitement and promise of these discoveries, there was a darker side to this era as well, marked by unethical experiments of trial and error and significant disappointment and loss of life. The opening scenes show the main character, Dr. John Thackeray, taking a horse-drawn carriage from an opium den through the streets of New York to work. It's grim, grey and just oozes a foul stench. The streets are crowded and there's even a dead horse lying in the gutter. Well, New York in the late 19th century was one of the dirtiest cities in the world, with death rates that were comparable to those of medieval London. There was human and animal waste festering on the streets, along with garbage and food scraps. Preventable diseases such as cholera and yellow fever would be rampant. Fortunately, the miasma theory of disease, which held that bad smells cause sickness, was slowly being replaced with the germ theory of disease. And in 1881, the city of New York established an official department of street cleaning in an attempt to improve conditions for inhabitants. Dr. John Thackeray, played by Clive Owen, is based in part on the real-life Dr. William Stewart Halsted. Now, Dr. Halsted was one of the most important figures in modern surgery, who invented many new surgical instruments and techniques in the early 20th century. And like Thackeray, he was known to be addicted to cocaine and morphine. Halsted is credited with performing the first emergency blood transfusion in the United States, and with revolutionizing the way that surgery is taught and practiced as a meticulous scientific discipline. In 1889, he was a founding professor, along with 3 other colleagues, of Johns Hopkins Hospital, where he headed the Department of Surgery. His cocaine addiction was a result of experimenting with the drug as an anaesthetic for surgery, and often on himself. In several scenes in this first episode, we see examples of bare-handed operating. In fact, in the mid-1800s, the mark of a good doctor was how much dried blood they had on their scrubs from other patients. This is probably not quite accurate in this series because around 1898, Dr. Halsted had already created the world's first rubber gloves for surgery. And the story around this is pretty cool. One of his chief scrub nurses was allergic to the stuff they used to scrub their hands with, a mixture of Purell and carbolic acid, and she got really vicious dermatitis from it. And because she was one of his favourite nurses and he wanted to keep her, and I think later on they fell in love and got married, he had a pair of rubber gloves made for her by Goodyear, the tyre company. Everyone after that wanted a pair of gloves, and you didn't have to keep on scrubbing with your hands, and surgeons started seeing lower infection rates.
Gentlemen, after 2 uneventful pregnancies, Mrs. Warren presented in her 8th month with what is assumed to be a case of placenta previa. The hope had been to delay any procedure for the benefit of the fetus, but circumstance has forced our hand. Dr. Thackeray and I have rehearsed the newest techniques extensively and feel confident that the speed necessary for success can finally be achieved.
So in this scene, we see the surgeons operating in front of a packed audience, the operating amphitheatre. And that was the way surgeons taught medical students, junior doctors, and other established doctors simply wanting to learn new techniques. And the most revered professor sat in the front row, and the young interns and medical students in the top row. Often the doctors would turn around and lecture the crowd, as Dr. Thackeray did in this.
Surgical knife. 100 seconds.
100 seconds. 100 seconds.
The first surgery scene we see is a failed caesarean section. Head surgeon Dr. Christensen gives himself and his team 100 seconds to complete the operation and stem the hemorrhaging of a mother suffering from placenta previa, a condition in which the placenta covers the cervical opening. As for surgeons trying to shave off seconds off their operating times, this dates back to the 1800s, so you could actually tell a top-notch surgeon back in the days by how quickly he could sever a limb, for example. Given there was no anaesthesia, speed was key.
I want the students to take note that Dr. Christensen is entering on the medial line just above the pubis.
We must be careful to extract the fetus quickly and in such a manner so as not to release pressure on the rupture, thus exacerbating the hemorrhage.
As you can see, there is significant blood in the cavity. Vacuum member.
This is actually a pretty accurate description of a C-section or caesarean section. The incision or cut Dr. Christensen uses is called a phalansteal incision or a pubic incision, and is a type of abdominal surgical incision that allows access to the abdomen and pelvis. It's commonly used for gynecological surgeries and is the most commonest method for performing caesarean sections today. The phalansteal incision offers a large view of the central pelvis, and this incision commonly is called the bikini line incision because the scar is hidden in the bikini bottoms or by the pubic hair. The incision does not distort the belly button and heals way faster than the traditional vertical incision. And exactly as shown here, the surgeon cuts on a generally horizontal, maybe slightly curved line just above the pubic bone.
Nurse Monk, knife. Knife.
Brody, how do I?
Her pulse is weakening.
This bloody scene transports us to another era in which childbirth was still dangerous for both mother and infant, as there were no real viable surgical options, such as a safe caesarean section in the case of any obstetric complications. The nurse, who is also charged with holding the sedation mask against the patient, also announces the pulse is weakening, likely because of severe blood loss. The nurse is also continuously monitoring the patient during the surgery and is updating the surgeons. Nowadays we have the anaesthetists who do this, and they have all sorts of equipment to measure the elements of the patient's physiology during surgery, such as an ECG, blood pressure monitoring, pulse, oxygen levels, etc. The scene here is also interspaced between the frantic spinning of the hand crank suction machines which remove the blood. Nowadays obviously we have it without the hand cranking. Dr. Christensen is unable to stop the hemorrhaging and the mother bleeds out.
I have a leg.
Pull the fetus down and
It's
out.
trapped in the cord.
Scissors.
Tube it.
Dr. Thackeray realises early on that the baby is trapped in the cord and instructs the nurse to intubate the baby. Globally, about 1/4 of all neonatal deaths are caused by birth asphyxia. This is where there's a failure to initiate and sustain breathing at birth. So similar to what happens nowadays, if you're concerned about a baby not spontaneously breathing, the team would attempt to resuscitate by clearing the airways. The nurse does this by trying to suction with a bulb syringe and trying to stimulate breathing. Additional steps we do to provide resuscitation is to warm the baby under a radiant heat source, positioning in a head sniffing position to open the airways. It's much better done nowadays.
Her pulse is faint and fully eccentric. She's pallid and her lips are blue.
Pebbles. 1, 2, 3.
We also see the pregnant mother's head being lowered, and their legs going up. Well, what's the point of this? There's a hypothesis that lowering the patient's head and elevating the legs above the heart helps to move blood from the lower extremities to the heart, brain and other vital organs. This is called the Trendelenburg position. The origins of the Trendelenburg trace back to the late 1800s when Dr. Friedrich Trendelenburg, a surgeon, pioneered this technique to gain better access to the pelvic organs during operative procedures. And during World War I, the position was utilised to the treatment of shock to increase circulation to the heart, increase the cardiac output and improve the blood flow to the vital organs, also known as autotransfusion. Trendelenburg became common practice in various healthcare settings such as emergency rooms, operating rooms and post-anaesthesia care units and critical care.
And a good day to you, Pete. How you doing there, fella? Got a nice little package there for us.
Now, this scene seems funny, but the underlying history behind it is pretty dark. Ambulance drivers back then were not medical professionals in any way. They were not able to provide any kind of help or first aid. They were basically trained horsemen who picked up people. And a trip to the hospital in 1900 was pretty much a death sentence. If you were going to the hospital, it wasn't to get better, but it was to obtain drugs or to ease your pain. And for these surgeons, they could attempt procedures that were brand new and untested. It was almost like you were donating your body to science.
You're not getting this one, Clary.
Oh, Pete. Can't we be reasonable? Talk about this like gentlemen. Now, as to my mind, you can either give us the goods or you can all travel to the Knick as patients. Booked a fine one. Banker from up Fifth Avenue. Liver problems, jaundice, piss and bloody sis. I'm sure this one will be in a private with us for a few weeks and be paying his bill in full.
Nice catch.
There was also a war between ambulance drivers. They were paid by the number of bodies they bring in to be cured. And this led to a lot of gang-style fighting. Imagine being the poor patient on the stretcher.
Dr. Gallinger?
This is Mr. Sebastiano Gentile, 40. On the 8th of this month, he was struck by a streetcar, fracturing his pelvis. Upon arrival, an extensive wound on the lateral side of his thigh was immediately stitched and dressed. Pulse was 112, abdomen was tympanitic, and there was tenderness below the umbilicus. So he was taken into the operating theater where we found 4 puncture wounds from the fractured pelvic bone lacerating the bowel. And with Dr. Chickering assisting, we immediately sutured the wounds using 3 catgut sutures on each puncture.
Now, this ward run is probably one of my favourite scenes. Dr. Everett introduces the first patient as someone who's been hit by a carriage and sustained a pelvic fracture, causing lacerations in the bowel. And he mentions using catgut sutures to sew the holes in the bowel. And catgut sutures have been around for a long time, but nowadays we have synthetic alternatives. Catgut sutures were old school absorbable stitches that were broken down by your body's enzymes. And if your cat is sitting with you as you watch this and is demonstrating concern where you can tell your feline friend not to worry, it never was made from actual cat guts. And theoretically, you could use your cat's intestines to make cat string, but when you compare the sutures you get from cows and sheep, it's not worth the trouble. A cow intestine can produce cat gut string that's 160 feet, and your cat's intestines are just small potatoes compared to that. At the slaughterhouse, the intestines from cows or sheep were usually slit in half, thirds or quarters lengthwise, and this would make different thicknesses for different uses, and these are then soaked in a series of solutions and caustic solvents which dissolves away all the tissue except the strong collagen fibers. And once all these fibers are clean and pure, it's then stretched, twisted and allowed to dry under tension. And what remains is the catgut string, pound for pound one of the strongest strings there is, and actually comparable to a weight of steel wire. In fact, the cat part actually started out as kit. It's a medieval era mini violin, and it was so mini that it was stored in a pocket in the 15th century, which was derived from the Old French poc or bag. Travelling minstrels could whip out their kit and play a lively tune or 3 and then put their handy instruments back into their pocket without worrying about the delicate frailty of a normal sized violin. Anyway, back to more medicine.
Was there any consideration of removing the damaged section of the bowel?
The difficulty in reconnecting the 2 new ends of the intestine seemed too great, and the danger of postoperative bowel leakage is another complication we discussed, and I dared not risk a resection.
Any complications thus far?
Mr. Gentile has developed a small case of bronchitis, which is common after such a procedure.
Very good, Doctor.
There are several interesting things here. Thackeray asks if he considered removing the affected bowel, and Everett says no because he was worried about a leak and the complexity of the procedure. Well, if there were any concerns about damage to the bowel, especially in a trauma setting, surgeons nowadays would remove that bowel. The patient is also diagnosed with a post-operative bronchitis, and nowadays we call this a hospital-acquired pneumonia or HAP. Often the patient's breathing and ventilation isn't great after surgery. They're in pain, so they don't take deep breaths, and they're lying down and not moving as freely, so at high risk of getting chest infections.
Health inspector, open the door, please. Mrs. Krawitz, we're here to take you to the hospital. Do you understand?
Now, doctors in the early 1900s had already determined that tuberculosis was spread through the air and travelled more easily in cramped, stuffy living environments, and that's how most people in New York City lived at the time. So the authorities had to step in.
No windows, no ventilation, no sunlight inside or running water. Breeding ground for disease, that's why the new laws were passed. I can compel you to make any and all structural changes to your property I deem necessary to protect the public.
No windows, no ventilation, no sunlight inside, no running water, a breeding ground for disease, and that's why the new laws were passed. This is what Inspector Jacob Spate tells the landlord. I can compel you to make any and all structural changes I deem necessary to protect the public. So when Spate actually makes this observation, he's trying to get a bribe, but the laws he's referencing to are actually legit. In 1901, the Tenement House Act required improved living conditions for the impoverished renters, and this wasn't done out of the goodness of anyone's heart. That'd be crazy. I mean, this was to curb the growing tuberculosis problem, and for the most part it worked. Before these legislative changes, the Centers for Disease Control and Prevention estimates that 194 out of every 100,000 people in America died of TB, and by the time they were widely adopted in the 1940s, it was down to 46 out of every 100,000.
I want you to stay like that for 20 minutes, Mrs. Eberhardt. Nurse Connolly will keep massaging your belly. Trust an old midwife. That breeched baby will turn around in no time to get away from the cold.
Is this something the doctor prescribed?
He would, if he knew what he was doing.
Here we see a pregnant lady belly first over a tub of ice cold water as a treatment for a breech baby, and this sort of stuff certainly was done back in those days. Babies often twist and turn during pregnancy, but most will have moved to the head down or the head first position by the time labour begins. However, that doesn't always happen, and a baby may be bottom or feet first, the breech position, or lying sideways in the transverse position. If your baby is in a breech position at 36 weeks, you'll usually be offered an external cephalic version. This is where a healthcare professional, such as an obstetrician, tries to turn the baby head down by applying pressure on the abdomen. It's a safe procedure, although it can be a bit uncomfortable. Around 50% of breech babies can actually be turned using ECV, allowing a vaginal birth. And we see some evidence that maybe the nurse or midwife is pressing on the abdomen, but I'm not totally convinced.
Septicemia, following a bowel repair.
We need to go back in and find the leak right away.
We can't go back in. Bronchitis. The ether will kill him.
He needs an immediate resection. 2 slippery pieces of bowel. Wet noodles somehow sutured perfectly together while septic fluids leak all over the cavity, poisoning the patient. That is, if we are somehow able to bring about surgical sleep without killing the man.
So here we have the patient who has had the operation and is now septic, or has septicemia in his bloodstream. To determine sepsis in real life, we use various criteria to determine this. So seeing how the patient looks clinically, physiological derangement, looking at the blood pressure, pulse and temperature, all these SIRS criteria, and blood tests as well. Clearly in this case, the patient has had a recent surgery and has now got a surgical emergency, which is thought to be a leakage of bowel content from the holes in the bowel, and that's pouring freely into his abdomen, driving the infection and causing peritonitis.
Normally, we would induce surgical sleep with ether, but due to a severe case of bronchitis he's developed postoperatively, we cannot. Pain. I intend to inject a 2% cocaine solution directly into Mr. Gentile's spinal canal.
Now, this patient was taken into the operating room and they realised that they can't give him an anaesthetic because of his bronchitis or his chest infection, which makes him a high-risk candidate for any anaesthetic. So the solution was that of a spinal tap and applying the cocaine solution that would numb his nerves but leave the vital organs unharmed. This is known as a spinal anaesthetic or a spinal block and is administered, Houth did, by injecting drugs into the area called the subarachnoid space near the spinal cord. Spinal anaesthesia can be used while you're awake or in combination with sedation or a general anaesthetic, and we still use it to this day in these high-risk patients.